Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Sagg, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, October 10th, 2024, we are speaking to Dr. Jennifer Cates, a Senior Vice President and Director of Global Health and HIV Policy at KFF. Dr. Cates oversees policy analysis and research focused on the U.S. government's role in global health and the HIV epidemic. Dr. Cates is particularly known for her work analyzing donor government investments in global health and tracking major U.S. HIV programs, an area she has been working on for close to 30 years. Today, Dr. Cates joins us to compare and contrast healthcare policies from different sides of the aisle. Jen, welcome to the podcast.
Great to be here. Hi.
Hi, it's so nice to have you. We got a lot to talk about, so let's just kind of dig in. Let's start with the Affordable Care Act, ACA, otherwise known as Obamacare. Where are we today with the ACA?
I think broadly speaking, the ACA, which was a massive transformation of the U.S. healthcare system when it was initially passed, quite a while ago now, it's really part of the fabric of the U.S. healthcare system today. So much of what the American public experiences in the way that they get their healthcare is almost everything actually is touched in some way by the ACA. So from that angle, it is really just our healthcare system at this time.
Yeah, it is. And I remember the controversy about it, and correct me if I'm wrong, but originally the concepts that were proposed by the ACA were really a Heritage Foundation concept, right? In response to the Hillary Care of 1992-93. And the Heritage Foundation's been in the news a lot lately with Project 2025.
Mm-hmm.
So it came from a right-wing, if you will, think tank. And yet, when it was discussed on Capitol Hill in 2009, 2010, it was brought forward to have bipartisan support, and it had anything but. Do you remember those days?
Yeah, I mean, some aspects of it came from different political sides, but as with everything with health policy, it really depends on who the architect or the apparent architect or leader or the one promoting the policy, and everything has become so partisan that it just splits along partisan lines. So it's interesting because the basic ideas of the Affordable Care Act, when we poll on that, people love the ideas, love it. If you don't call it, Obamacare or the Affordable Care Act, people want all the things that are in it. So it is quite popular, the provisions of the ACA.
Yeah, especially the policy of pre-existing conditions being covered. I don't know any other way to do that. And maybe you can talk about these attempts at repeal, especially in 2017.
Yeah.
They were going to get rid of this. And part of the intricacies of the Affordable Care Act is that it's built around these coverage of these previous conditions, and it all has to interact, otherwise it falls apart. And if you take away part of it, the whole thing kind of fails. What did you sense that the opposition, if you will, in this case, the Republicans in Congress, wanted to replace it with if John McCain hadn't done that?
Yeah. Right. So in general, because of the partisan differences about the idea of the ACA, Republicans have been, trying to repeal it for a long time, or have made many attempts to repeal it. None of them worked. And I think part of the challenge that they faced is, first of all, a lot of the provisions that we have come to now just accept as part of our healthcare system are very, very popular, as I mentioned. But in addition, they didn't really ever come up with a replacement. So it wasn't really clear what, if this went away or that went away, what would happen. And so there wasn't really a good path forward. And this is happening right now in the current election. Trump, as a candidate, has hinted again that he's going to have a different plan, a concept of a plan. There's been some discussions about the pre-existing conditions protections, which is very popular, and threats to that. So, some of it's these arguments are being recycled, but nothing's actually been put forward as a replacement. So, unclear what would happen. But there's certainly, when Donald Trump was president, he chipped away at some aspects of the ACA. Not the whole, wasn't able to do the whole thing, but definitely chipped away at some of the protections or challenged some of the protections that help the average person get healthcare that they need, made it more difficult. Didn't have much funding for outreach to enroll people. So those kinds of things could potentially be in play again if he were to be elected.
Yeah, and that's what I think we're concerned about. One of the aspects of Obamacare or the ACA was Medicaid expansion, and this was
Hmm.
an option for the states. They could elect to opt in or not. It's been a slow process for a lot of states, especially in my neck of the woods in
Yeah,
the South. Our state, Alabama, has not expanded
right.
Medicaid, and a few others. Mississippi did, if I understand correctly, and Louisiana has, and Arkansas, et cetera. Um, What's your sense of why those states have not expanded at this point?
Yeah. Well, let's back up a little bit. When the ACA was first passed, actually Medicaid expansion provision was mandatory. And there, the idea was the federal government said to states, we're going to give you essentially 100% of the cost of expanding your Medicaid population to more people that really need healthcare that can't get it in your state. We'll pay for it. And in fact, we'll pay for it for quite a bit of time, and then we'll pay most of it for forever. And because of politics, that provision was challenged and won in the Supreme Court in a sense to say, okay, the federal government can't require this, states have to opt in. So that's the system we have. The fact is, it's a pretty good deal. I mean, if you think about it, a state is shouldering the burden of care for uncompensated care and other care that they have in their state for someone who doesn't have insurance. So this is basically saying, the feds are going to pay a very large share of expanding coverage. So what has happened over time, something that was extremely partisan, now only 10 states haven't taken up Medicaid expansion. Most are in the South, as you said. I think though it's one of these, it's a long arc situation. I think it's going to be really hard over time to not have states move in this direction. People want it. It's financially, it makes sense, and it's we who knows because everything is so political. But there are red states that have expanded Medicaid, and it's been quite popular. So I think it's TBD, but the trend is in that direction
Yeah, and it's 100% of the coverage. In other words,
for a period of
if
time.
we have X number of people on Medicaid today, they expand whatever the Y for X plus
Yeah,
Y for the expansion. 100% of those new individuals covered by Medicaid are covered by the federal government. And then, as you said, it drops off.
yeah,
I think no less over time sort of gets fixed around
yeah,
90%.
yeah. Yeah, I
And
mean, it's not quite as generous as it was initially, but it's much more generous than the typical medic share with the federal government for Medicaid. I mean, it's basically a way to expand coverage where the federal government's paying for it,
right.
and it really is all the studies that we've done and others have done show that the impact on health outcomes has been significant in improving health outcomes and of course improving coverage.
Yeah, and that's kind of one of the things that I'm personally concerned about in Alabama. For example, rural health care is
Yeah.
really tough. Hospitals are closing. I keep wondering whether those hospitals might have been able to stay open had the state expanded Medicaid. Do you all have studies on that or data on that?
We might. I can check. Yeah, we have. I have colleagues who are looking at all aspects of the healthcare system. And the hospitals are especially in rural areas, underserved areas. There's a lot of challenges for those safety net hospitals.
Yeah, it really is, and especially getting
Yeah.
obstetric care and
Yes.
other things. The one thing that people can get access to, as a general rule, is HIV care. Ironically,
Yeah.
because of the Ryan White Care Act. You want to maybe talk to us a few seconds about the what the Ryan White Care Act is and how it helps
Yeah.
people?
Yeah. So HIV care in this country, it's been an interesting trajectory. As you said, there's something called the Ryan White Care Act, which was passed by Congress in 1990, and it essentially is a federal program that provides funding to states and local localities to provide care, treatment, and other services for people who are HIV positive who don't have insurance or can't fully afford their insurance. It's a lifeline, actually, a safety net below the safety net. And that program has been responsible for us not only saving lives, extending lives, have excellent health outcomes. that program in conjunction with Medicaid expansion has really, served to make a huge difference, even though there's still challenges in the US, but it's been an incredible lifeline that is, unique to HIV that program exists. There's not really an analogous program for people with other health conditions like that.
Right. And the justification why, in my opinion, it's bipartisan is because on one hand, it
Yeah.
helps an individual. It also helps, as we know now, reduce transmission. It's a win-win
Definitely, yeah. If you're
getting
on
access.
HIV treatment, as you know very well, you're virally suppressed, you're not going to transmit HIV. So not only are you your health is greatly improved, you really can drive down new infections.
So what's a little bit wacky here in Alabama is that a lot of people who ordinarily might have had some degree of health insurance through Medicaid expansion are uninsured.
Yeah.
Therefore, they come through us, through our clinic. The Ryan White Care Act kicks in, and what they do statewide, instead of having something called ADAP program or the
Hmm.
AIDS Drug Assistance Program,
Hmm.
they will purchase a private insurance
Hmm.
uh,
Plan,
policy,
basically.
right,
Yeah.
policy. So they'll end up with something maybe even a little better than
Yeah.
Medicare, Medicaid,
Hmm.
that gives them coverage. It's not something that I'd rather have the Medicaid expansion, but for a lot of people who otherwise would have been uninsured, they actually end up with health insurance.
No, it's actually something that was realized years ago in the Ryan White program. I think quite an innovative idea, which was it's actually less expensive to purchase a health plan for somebody, pay the premiums for somebody to be in a broader risk pool where there's the costs are driven down by a larger population than to purchase drugs individually for that person. It's cheaper. So Ryan White programs over time have really moved to that model, which is let's for states that haven't expanded and also states that may have somebody in the marketplace plan that needs additional help. Ryan White can support other costs, can support premiums, and it's very cost effective. So it is a strategy that the program allows.
Yeah, we hadn't said this, but it's important for people unfamiliar that the mantra and the mission of the Ryan White program is to fill gaps. So wherever that
Yes.
individual is, if they have a gap in their coverage, a gap in their care, it's a fabulous program, and it's really, as you said, saved a lot of lives and helped a lot of
Yeah.
people. One of the things that we've done, and you may be able to talk to this a little bit, is that
Hmm.
we were eligible, we discovered, for something called 340B
Hmm.
funding, which in essence allows us, we linked it to our Ron White grant, which is interesting because that means that whatever rules apply to our Ron White grant now
Hmm.
apply to our 340B program.
Hmm.
That's a little bit unusual, but what it means that every dollar that we can generate through the 340B program, we have to use in the exact same way that we would use it for Ron White. It's a little bit of an exception. For most people, the 340B applies to a hospital system or an entire health system. But could you spend a moment or so explaining
Yeah.
what 340B is?
Yeah, so 340B is a federal program that, when it was passed, was intended to help uh, safety net providers primarily to be able to serve uninsured and low income people by lowering the cost of drugs that they had to purchase for those populations by giving them a bigger discount essentially for those drugs and allowing the use of that savings to kind of go back into programs and services as long as it was to expand access. So that has really allowed not only, these savings have been significant and it's allowed, I know in your case, but around the country, because all Ryan White entities are eligible for this, as many other kinds of safety net providers, to greatly expand their services for people who are underserved. So that's the intention of the program. That's what's happening. That's what's happened. But unfortunately, it too it's been challenging because there's other entities that have been using that are technically eligible, but it's not always transparent where their savings are going, and so that's created some concerns, particularly on the Hill, but also the Government Accountability Office, the various Inspector General reports from the federal government saying, we have to have a little bit more oversight of what's happening with this program so that the actual intended purpose is what's happening, not to subsidize other healthcare.
Yeah, the way it works, I think, just to get a little concrete
Yeah,
about it, you explained it very well. But in our case, let's say
yeah,
if we were going to purchase medications, or our pharmacy was going to purchase medications at the usual average wholesale price or some discount
right,
thereof, that's the standard payment that we would have to pay to the drug company to get
right.
that medicine. This 340B allows us to purchase at a substantial
Yes,
discount below that usual purchase price, but yet when we collect from a third party payer, we
you
can
get the
collect
full.
at
Yeah,
the stand amount. So you get a
yeah,
pretty large amount of money per prescription.
right.
It gets plowed back into the program to be used for access, as you said. So
Yeah,
that can generate a good amount of money that is used in
for
our case
access.
in the
Yeah,
spirit of Ron White. But what it means to the drug companies is that they're selling their product to 340B entities for a lot
they're
less.
getting less. They're getting less money.
And so I guess they're not terribly excited about continuing this program over time.
Yeah, I think there's different stakeholders in this fight. I guess there's drug companies that have an interest in the getting the maximum price they can. There's hospital systems, some that safety net providers, but others that have access to this as well. And I think there's some concerns. Are they funneling the money, putting the money back into services for these populations? There's Congress, which has concerns about oversight and just really making sure that the intended purpose is what's happening. And all of these are kind of clashing at different times. So it has put pressure on the program. And I think there's different factions where, Ryan White providers and other safety net providers are saying, wait a minute, this program has, allowed us to serve so many people. And if our ability to access it is curtailed, that will have direct impacts on people. And so that's one side. And the other side is, well, we can't have big hospital systems getting these huge discounts and maybe using it not for those purposes. So it is a tension right now.
Yeah. And I think there's a lot of energy that might be transmitting over to Congress to
Yes.
curtail the program,
Fix
revise
it,
the
maybe.
program.
Yeah.
Yeah. And so
There was a
that's,
hearing just a few months ago on this. And, I think both sides of the aisle in that hearing, reiterated the importance of the intent of the program, but wanting to see more, having more reins on it, I think.
yeah.
Yeah.
And that kind of makes sense to a point. And
Yeah.
something, again, to watch as this election evolves, whether not just the presidential election, but who controls the Senate, who
Yeah.
controls the House. And that's going to have a lot of impact over at least the next 2 to 4 years of how discussions will go for 340B. Would you say, in your opinion, that while 340B may be challenged or modified, that you sense that the Ron White Care program is pretty protected at this point?
I do. I mean, there's no obvious harm or concern about it directly. It has bipartisan support on the Hill. When President Trump was in office, it was supported. I think the bigger issue for Ryan White is just the downward pressure on budgets
Yeah.
and what might happen over time. And then also, if just how can Ryan White, just from a Ryan White perspective, what can it do in the next decade to really reach national goals, to try to mobilize, in different ways potentially to drive down new infections, to reach those who haven't been reached. How can the program do that? But I think from a big perspective, it seems relatively secure at this time.
Yeah. And just again to get into the weeds a little bit,
Mm.
when that law was first passed, as you said, in 1990, it had a sunset provision that mean it had to be reauthorized, and it got reauthorized several times. And I think on the last reauthorization, they took away the sunset provision, correct?
Well, what happened was the way, just in broad terms, there's things called authorizing legislation. They create new programs, they create new departments sometimes. And if the language in the law of an authorizing bill has a date in it, like this program only exists till this time, or this provision only exists till this time, that sunsets it. So unless Congress acts, that they can't legally continue it. Much of the things in the Ryan White Care Act actually were not sunset, but there were a few provisions that were. And so the last reauthorization was many years ago, and because of frankly the politics on the Hill around healthcare, It has not been put forward for reauthorization. So there was a lot of some of those provisions just went away. Um, so the Ryan White's safe in the sense that nothing stops it from continuing as long as Congress appropriates money. But some of those provisions, there were some provisions that had to be, were adjusted. Yeah,
And for people involved in HIV care and prevention,
yeah,
with all the emphasis on PrEP, which is pre-exposure prophylaxis,
yeah,
preventing infection among people who don't have HIV but are at risk for it, they are not eligible by that law to be covered by Ryan White. So therefore, medications that might be
yeah.
pricey, or that are pricey, aren't covered by Ryan White, and a Ryan White clinic cannot take care of someone who is not HIV infected per se. Is that accurate?
Yeah, so that the law and the program was set up to help people who have HIV. And Ryan White is allowed to do outreach around some risk reduction, but it can't pay for prevention.
Right.
PrEP being a key example of a medication that is so successful at preventing HIV infections. The good news is that most insurance plans, are almost all, have to cover or will have to cover PrEP for free,
Right.
at no cost to the individual. It's still an issue for people who are uninsured. There is no Ryan White mechanism for them. So that becomes a whole other issue of how does that get done. The drug companies have, programs to provide it, but there's not been a good solution. And consequently, PrEP uptake has been not great in the US, particularly among populations that have less access.
Yeah, or like a state like mine that has no Medicaid
Yeah,
expansion. So here there is a huge disadvantage in that regard.
definitely.
Well, our time has gone by quickly. I do want to get to one other issue about public health in general, and it's kind of, in my opinion, a a remnant of the COVID epidemic,
Yes.
and that is what I call the assassination of the trusted voice.
Hmm.
What I mean by
Yeah.
that, we can take Tony Fauci as an example, but there's plenty of others who was out in front and trying to give the best advice to the public.
Hmm.
From a very scientifically sound perspective, and yet over time became the target of a lot of hate and, in fact, in his
Yeah.
case, death threats,
Yeah.
a lot of ridicule on Capitol Hill from, in this particular case, Rand Paul, most notably Marjorie Taylor Greene, a few others.
Hmm.
Um, and it sort of erodes the ability of us as a country to have a voice that we can
Yeah.
rely on when, not if, when the next pandemic hits or the next healthcare crisis. What's your perspective,
Hmm.
having been in Washington for a long time? You have concerns about this?
I do. I mean, I've been in Washington a long time, as you say, and I've never experienced what we have been through, and what it did to permanently alter the sense of the trust that people have in science and public health. And why is that? So COVID did a few things. One was it terrified most people, right? So when fear is present, it's a very powerful motivator in some cases, but also people act in different ways when they're afraid. So that was the case. We had a president at the time who did some very important things around COVID. Donald Trump, Operation um,
Warp speed.
right, Warp Speed, which really did, in a warp speed from a vaccine perspective, get vaccines out. But also at the same time, everything became very partisan. And that happened pretty quickly. And so his administration began to be at odds with public health practice. And that just evolved and became much, much worse. And I don't believe we've recovered. So, and you throw into the mix disinformation, misinformation, by many different sources, and it's hard for the average person to sort out what's a fact or what's not. We're in a very different place, and I think there's also a fundamentally different view that the different parties have towards public health. So in general, and this isn't a generalization, but I'd say the Republicans have had more of a leave it up to states approach. Don't encroach on what states want to do, let them decide. And the Democrats have had more of a, well, there's some national standards and some things that we need to have across the country. And that has created a tension. That we saw that during COVID, and I think that will continue. And some of the rhetoric that we hear on the campaign trail about, if any school tries to mandate vaccinations, they're going to lose their funding. So this has just become an incredibly politicized area at a level that was not the case. Our polling shows that the trust has gone down, and it's dramatic.
Yeah, I think we all have to work on rebuilding that trust,
Yeah.
and I think it starts with explaining what it is that a public health official does,
Yeah.
and how they use science. The analogy that I use is a public health official is no different than a physician taking care of an individual patient,
Yeah.
except in this case, the individual patient is a population.
Yeah.
And when I walk in a room with a patient, the initial assessment, I'll explain what I think is going on, but then I collect more information.
Yeah.
And as these data come
Exactly.
in, I modify what I
Right.
said because it's not the same as it was, say, in this case, February 2020. We learned a lot more by
Yeah.
April of 2020. Hospitals were becoming overwhelmed. The use of masks were viewed to be important where they weren't emphasized initially. But that changed, that the political term would be flip-flopping on a
Hmm.
topic. We don't think about that when I take care of a patient, but yet in the public health arena, that tended to be a missile of sorts that the misinformation folks would fire back at the health official.
100%. I actually use a similar analogy, and it is exactly the case. When you go see your doctor and they say, well, we think it might be this, we have to do more tests and figure out the diagnosis, everyone says, okay, trust the doctor, run my tests. Public health official says, this is what we know today. We don't know when we'll have a vaccine. We think you should wear a mask. People don't like the uncertainty, and it's hard to talk about. So we're at a difficult place, and maybe we need to push that analogy out a little bit more.
Yeah. Well, we all have a lot of work to do on that arena.
Yeah.
Jen, our time has really flown by, as I knew it would.
Mhm.
Can you can you give me a reason to be optimistic about the future? It feels kind of scary right
Hmm.
now.
Well, what I come back to are two things. One is, you and I both have been working in HIV as our primary focus for long parts of our career, and you have to be optimistic when you do that. It's just part of what motivates us, right? And we've seen, despite some challenges, there's been so much to be optimistic about. So that's a motivator for me. The other is, you always have to look to the future generation. I have a kid. I want them to have a better whatever life out there. And so we have to be optimistic for them and just do what we can. And I think, that's a common feeling by many, and probably more of the silent majority than we know.
Yeah. Love that. That's a great way to end. Thanks for being with us. And I really feel good about what we covered. And I think folks have learned a lot from this conversation. Thanks for being with us.
Great. Thanks for having me.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.